So I'm Lorraine Johnson, and I'm the executive director of LymeDisease.org, for those of you who don't know me. And I want to thank everybody for taking the time today to come here to show support for this cause. I think it's a critical cause, and we need to get attention dedicated to what's going on in the Lyme community and what we can do to fix it. So most of us here know that Lyme is a big problem for a lot of people. And I just want to do a show of hands of how many people here have been diagnosed with chronic Lyme disease. Okay, so that's most of us. And how many of you were diagnosed within 6 months? So there's two. There are two people who are diagnosed within 6 months. And so people in the Lyme community know that that is a very big problem, because time to diagnosis makes a big difference in how the course of the illness goes, how treatable it is, and whether patients get well. And the government is beginning to acknowledge that Lyme is a big problem. They just increased the case numbers to 300,000 from 30,000. That's 10 times higher. They were off by a bit. And it's important to get the numbers right, because research funding is driven by numbers. And so when you look at those numbers, what they're telling you is that the research allocation that should have been dedicated to research in Lyme disease was not allocated. We haven't had the research that this disease needs. So let me put the 300,000 cases per year in context. That's 50% more cases than are diagnosed in breast cancer each year, and it's 6 times the HIV annual diagnosis rate. So this is a very big problem. But we still think that that number is low, and let me tell you why. The study that it was based on had 7 out of 10 labs. Well, what about the other 30%? What about the other 30% of the cases that would have been represented in the other labs? That study did not include any patients that were diagnosed based on an EM rash. So those patients were excluded. And then we all know that false negatives can be a real problem in Lyme disease. So what about all the people who were actually tested and tested negative? And then what about those patients who went in to be tested and were denied testing by their doctor because Lyme disease doesn't exist, or it doesn't exist here, or anyway, you don't have it and I'm not going to take the time to find out. So we estimate that the real number of new cases each year is between 500,000 and 1 million cases. And that's a very big number. And this is just how many people get Lyme disease. So how many become chronic? Well, a recent study now suggests that about 35% of those with early diagnosis and early treatment develop chronic Lyme. And that's with early diagnosis and early treatment. That's not all the patients here who didn't get diagnosed within 6 months. So we're talking about millions and perhaps tens of millions living with chronic Lyme disease. The problem is nobody's really done the math or added up the numbers. So Lyme disease is not rare, and chronic Lyme disease is not rare. It's an epidemic of staggering proportions. And undercounting means a lot of things. For one thing, it means it's not a problem. For another thing, it means that research that is critical to treating this disease is underfunded. It means that we've had a lost decade of research in Lyme disease. So now that we know that there's a really big problem, we don't know what to do about it because we haven't developed the optimal treatment approaches for Lyme disease. And we know that during that 10-year period, there was a study that was lost, that was essentially lost. It wasn't tracked. It was the EMBER study. And that study showed persistence of spirochetes in the rhesus monkey through invasive tissue sampling after treatment with antibiotics. So we've lost a decade because the CDC couldn't count. And we didn't do the research necessary for optimal treatment. And we don't know what the optimal treatment is because we haven't bothered to find out. So looking at other diseases, for instance AIDS or tuberculosis, what we find is that these diseases are using combination treatment. They're using more than one antibiotic, and they're using them for a longer period of time. Suppose they had done a study of tuberculosis and had stopped at 30 days and said, it doesn't work. What would have happened to those people? Suppose they'd done a study of HIV for 30 days and said, it doesn't work, and abandoned those people. So we have no combination drugs, and we have no longer-term treatment approaches that have been tested. The longest treatment approach that's been tested in Lyme disease is 90 days. And if you talk to people with tuberculosis, the norm is 2 years. How are we going to get there to find out what the optimal treatment is for Lyme disease? And I think that this is going to take innovation from physicians with their hands in the trenches, and we need to give them the elbow room that they need to solve this. We can't do it by randomized control trials. Randomized controlled trials, you can do one every 5 years. It takes a long time, and you end up with a sample that does not reflect the people who are actually seen in the clinical practice. And the trials that we've had to date have been very small. They've all been less than 100 patients. So we're here today because the IDSA has developed a set of guidelines that deny care, and the CDC has blindly followed these outdated guidelines. Guidelines that do not reflect the current science. Guidelines that excluded patients and treating physicians from the development process. Guidelines that don't work, because 25% of patients fail early treatment when they're diagnosed early and treated for the 28 days. And the failure rate for those who are diagnosed late is closer to 45%. So we have a really big problem, and the CDC now recognizes that we need to do something about this. And what they're proposing to do is prevention. But what patients want to know is, what are they going to do about the patients who are sick today? And patients want to know, when are we really going to start looking for a cure? Where is our Manhattan Project with all hands on deck? So the question I ask the CDC and the IDSA now that we know that we have an epidemic, are we going to do anything about it? Because it's time to recognize that the CDC and the IDSA policies over the past 10 years have failed. Their approach of excluding patients and their treating physicians from solving the problem can't work and hasn't worked. It has not improved the quality of life for patients. And you know, the litmus test for a good guideline is whether it improves patient care and whether it improves their quality of life. And what we have here is really treatment guidelines that have devastated patients. So patients and physicians in the trenches need to be part of the process. And patients, as we know, are the single most important stakeholder in healthcare. It's our lives on the line. And if you don't improve patient quality of life with guidelines, you have not addressed the key issue. So it's time for a change. It's time for, as a recent article on the British Medical Journal says, it's time for the patient revolution to begin. Nothing about us without us. And the time to do it is now, and the way to do it is to simply do it. So thank you for your time.